I'll start. So we're very honored to have Dr. Sumit Subudhi with us today, talk about the cutting edge of immunotherapies and prostate cancer and other topics, whatever his research is. We'll catch up. And I just want to start with our standard disclaimers, which are two. One is that this is not medical advice. This is information for consideration for you to take to your medical team. And the second is that everything you say can and will be made public. So we don't hold back, hide your screen, change your name or whatever. If anything you say will be on the transcript, and we will make it public, and it will be in the recording. So with those two disclaimers, turn it over to Dr. Subudhi. I'll just mention that we of course all know about the unfortunate passing of our good friend Bryce Olson, who was an inspiration for all of us. And the first time I met Dr. Subudhi was when Bryce originally put out his cry for help. He'd kind of run out of pathways to drug, and he was saying, I've hit a wall, I don't know what to do. We reached out to Dr. Subudhi, and he was calling Bryce on a Sunday evening. I mean, he was immediately, tell me more about your case. I'm there for you. I'm very supportive. He was amazing. He's been that kind of person who's just sort of, when there's a cry for help, he comes back and he helps the people with their decisions. So very, very appreciative of Dr. Subudhi's availability, knowing that he's a very, very busy and very accomplished clinician. So that was our first interaction with Dr. Subudhi, and so always feel very honored and grateful that he is able to do that when people need help. So with that, Dr. Subudhi, thank you for taking the time today to join us and to share. As usual, we try to have like 5 to 10 minutes of introduction, and you can just sort of maybe have some slides, and then I'm sure that we'll have questions from the audience.
Okay. Well, thank you, Brad, for that very kind introduction. And sorry, I actually didn't know that Bryce had passed away, but sorry to hear that. He was definitely a fighter. And so prostate cancer is personal to me. My father himself has prostate cancer, and he's battling that, and he's being treated at Memorial Sloan Kettering Cancer Center with his treatment. And what I told him is what I tell my patients is that I want you to live as long as possible with the best quality of life, and in the process, let us try to find you a cure. And I strongly believe that immunotherapy is going to be the cure. Just a little bit about my background. I did get a PhD in immunology at the University of Chicago, and then I did my training at Memorial Sloan Kettering, where I met Jim Allison, who won the Nobel Prize in immunology, and I was in his lab while also getting clinical training with Howard Scher at Sloan Kettering. And then when Jim got recruited to MD Anderson, he asked me to help develop immunotherapies in prostate cancer. And so I've been at MD Anderson for almost a decade now because of that. And I'm going to share with you where I think the directions are going. And by the way, Dr. Subudhi is the name that when I'm wearing a white coat in clinic, but in this, if you don't mind, just refer to me as Sumit. The way you say Sumit is Sue as in a girl's name, Mit as in a baseball mitt, and so Sumit, okay? And please interrupt me at any time. I want this to be informal, and I have a few slides that I'll start sharing with you. And I should point out that in the last decade, all I see in clinic is prostate cancer patients and nothing else. And my focus is on immunotherapies and prostate cancer. Is this in the right mode? Can everyone see the screen? Yes.
We can see it. It was better the way you had it before. I don't think you're. I think you're in presenter's mode.
Got it. I'll switch it. Here we go. How's that?
Perfect. Yep.
Okay. So title that Brad helped me with is New Developments in Immunotherapies for Treating Metastatic Castration-Resistant Prostate Cancer. The truth is, we're going to apply these same concepts in other settings, localized disease, as well as biochemical recurrence and hormone-sensitive prostate cancer. Here are my disclosures, none of which are relevant for what I'm going to talk about today. So why immunotherapy? And it's because the immune system can eradicate tumor cells. We've all known that the immune system can be used to fight infections, whether viral, bacterial. We are even, as example, COVID, where many of us have been vaccinated to help fight it. So we're trying to manipulate the immune system to also kill cancer cells. Why? Because the immune system is adaptable, meaning that as the cancer transforms, a good immune system will recognize that transformation and still recognize that cancer and be able to kill it. It has specificity, and more importantly, it has memory, meaning that you should be able, with a good immunotherapy strategy, get a memory response that's durable, if not curative. Okay, and that's unique from many of the other drugs that we have in prostate cancer, where usually on average we get about 6 months to a year out of many of our drugs. So this is a complicated slide, but there's one or two main points I want to get out of it. It's an old slide from 2008, but it really gets the message out. So in the middle here is you have the tumor cell, right? And surrounding it is a bunch of immune cells. And what I want to point out is that not all immune cells are good. So all the ones on the right-hand side of this tumor where my pointer is, these are all examples of immune cells that help the cancer grow. And all the ones on the left-hand side here are the ones that help kill the cancer. So when you hear that, oh, this cancer has a lot of immune cells, the next question you have to ask, are they the good ones or the bad ones? And just because you have a lot of T cells, I'll give you an example. Here is an example of a T cell that's actually bad for the cancer, or sorry, bad for the patient, but good for the cancer, meaning regulatory T cells help the tumor grow, whereas CD8 T cells that are cytotoxic and have the ability to kill the cancer, these are bad for the cancer and good for us.
In a quarter mile, turn left onto North 8th Street.
So that's got to be the driver. And so again, the first point is not all immune cells are good. The second point is when we give immunotherapies, our goal is to shift the immune tumor microenvironment in a patient's cancer, so we're getting less of the bad ones and more of the good ones. Okay, that's the goal of immunotherapies, and then we hope that will then lead to durable or curative responses. So what's with prostate cancer? Why is it different? Why has it been a harder type of cancer to sort of make segue with immunotherapies, which is in contrast to what we see in lung cancer that Ricardo can attest to, as well as melanoma, and so what we call immunoresponsive cancers. And why one of the problems with prostate cancer is there's very few T cells present. And so this is a protein staining of a patient's prostate cancer, and the brown staining is the T cells, and there's just very few there. If this was melanoma or lung cancer, most of this would be covered in brown staining. And then what I'm showing here on the right is that there's also bad immune cells known as suppressive myeloid cells. And there's actually a graph that shows an inverse relationship. So the more of these bad cells you have, the less of the good T cells you have. And that's what this graph shows, that there's an inverse relationship within the patient's prostate tumor, and each symbol here represents an individual tumor. So different prostate tumors. And so what I showed in the top was soft tissue, but in patients with bone metastases, the same thing holds true. So right here, this dotted line is the patient's bone metastasis. Surrounding the bone metastasis is normal bone marrow, which is chock full of T cells, but inside the cancer itself, there's very few T cells. And again, when we look at these suppressive myeloid cells, looking at a marker for them, CD206, you can see inside the tumor itself, there is very little of these, there's very few T cells, but a lot of these suppressive myeloid cells. And why does it matter? Because bone metastases represent somewhere between 70 to 80% of patients with metastatic castration-resistant prostate cancer. So it's something that we see in clinic quite a bit. And if we're going to try to cure a majority of patients with prostate cancer, we do have to think about the bone microenvironment. So what are the approaches to drive T cells into this prostate? So there are vaccines, and one is already FDA approved since 2010. It's known as Sipuleucel T, or Provenge. And Larry Fong's group at UCSF has shown that you can actually drive T cells in to the tumor site. This is a soft tissue tumor site. Our group has shown that you can use immune checkpoint therapies or immune checkpoint blockade with anti-CTLA-4, in particular ipilimumab, to drive T cells in. And what this high magnification is showing is that the T cells are right next to the tumor cells. So you're really getting them right there. And then more recently, the group at Penn, led by Carl June, has shown that PSMA CAR T cells can also drive T cells in. They're using a yellow staining here to show the T cells getting into the tumor, which is in green here. So there are many different strategies that have been used, but the truth is most of these strategies have failed to work in the bone, and it's really hard to get it to work in the bone. So what other strategies are there? More recently, T cell bispecifics, they're now FDA approved in melanoma as well as in multiple myeloma and liquid cancers, and they're starting to make their way in prostate cancer. So how do these bispecifics work? I think about them as like a heat-seeking missile. So this is the missile right here. It's got two arms. One arm recognizes the T cell. The other arm right here recognizes the cancer.
Yeah, I'm on.
And so basically, it can bring the T cell directly into the cancer. And here's an example of a PSMA bispecific combined with immune checkpoint therapy, anti-PD-1, which is FDA approved in melanoma and lung cancer, among many other types of cancers. And what we're seeing is, here's a patient before treatment, before he received the bispecific plus anti-PD-1, and you can see I've highlighted the orange lesions, which represent lesions in the bone. And I told you how hot these lesions are by this metric called SUV max, these PSMA PET scans. I bet you Oliver Sauter probably showed you some of this when he was talking about his PSMA radioligand therapy called lutetium. And then after treatment, you can see that one of these, it's almost disappearing. And this is only after a couple of treatments. And so you can see the numbers going significantly down. So we've now shown with biopsies that we're actually driving T cells in here. So I believe that the backbone of immunotherapy treatments in prostate cancer is going to require T cell bispecifics. And with that, I'm going to open it up to questions, and I can talk more about our research, but this is the last slide that I have.
Thank you, Sumit. We'll use the raise hand feature for people to raise questions, and I will call on people to moderate. Does anyone have any questions? Bob Germankin. Sumit, Bob is a dentist and an advanced prostate cancer patient, so he knows about bone. So go ahead, Bob.
Yeah. Can you hear me okay?
I can.
Yes.
Okay. Yeah. So besides that, I also just recently started on Keytruda because I have all the biomarkers. So I have two questions. One is, with the NEP or the ICI, what, if anything, can be done to enhance the tumor microenvironment for infiltration? Because I know, like you said, it's pretty cold. And then the second question is, even if you don't get good T cell infiltration, has anyone looked at whether these, if you will, activated T cells work on circulating tumor cells and help prevent seeding?
Yeah. So great questions. So let me start with the first one. So I'm guessing. So let me back up. So Keytruda is anti-PD-1 therapy, and it is FDA approved for patients who have a high TMB or tumor mutational burden, or patients with mismatch repair defects. And this is in the context of prostate cancer. And so I imagine you have one or both of those features, and that's why you're getting Keytruda. Is that?
Yeah, I have, actually all three. I also have MSI high.
Yeah, so the TMB high and MSI high is related to the mismatch repair defect. So, okay. So with that in mind, just to let you know, the data that came out of Wasim Abita's paper at Memorial Sloan Kettering, we trained together when we were there. And he's shown that there's a 50% response rate with Keytruda or anti-PD-1 therapies alone with patients like Bob. But the durable response rate is actually 25%. So which of these patients is going to have lasting responses? It's only 25%. And so with my patients that have what Bob has, I actually don't offer them. Well, I do offer them anti-PD-1 therapy like Keytruda, but I really try to hold them when we have combination trials like what I just showed you on the slide, like a bispecific plus anti-PD-1, to try to enhance that durable response rate from 25% to something higher. So then Bob was asking, so what are choices that he could do to combine it? Well, if you're getting standard of care, one of the things I would consider is some sort of radiation therapy. Sometimes that can boost the immune system to sort of to make the Keytruda more effective. Again, this is more experimental. I don't have a lot of strong data to support it, but I do have the phase 3 trial with ipilimumab plus radiation, which almost became FDA approved, but just barely failed to meet its endpoint of overall survival. When they didn't combine it with radiation, the trial was a complete failure. So there's support of radiating some of the bone sites and making the immunotherapy more effective. But again, for most of my patients, I offer them Keytruda, but I tell them that if it was up to me, or if it was my own father, I would wait till we have a good combination trial to do that with. All right, and so that answers your first question. And Bob, part of that first question is we strongly believe that mismatch repair defects are very different in prostate cancer compared to colorectal cancer, where you might have heard last year out of the Sloan Kettering group, 18 out of 18 patients with colorectal cancer and MSI high all had responses to anti-PD-1 therapy. This is never going to happen in prostate cancer, and the reason why is prostate cancer is much more immunosuppressive. So even with the MSI high profile, you're only going to get approximately a 25% response rate. So I hope that answers your first question.
Yeah.
Your second question is whether or not you're hitting the circulating cells. And I would say the answer is we definitely are, because the 25% wouldn't have durable responses if we weren't. But do we have biological proof of it? No, we just have clinical proof, the fact that you're getting these durable or curative responses.
Thank you. Next up is Ricardo.
Hey, thank you very much, Sumit, for your time. I really appreciate it. so like Brad said, I'm a little bit different because I'm on the lung side, so it's different than the prostate side. Not only on the lung, but also oncogene driven because it was ALK. So but there was a transformation from ALK non-small cell to small cell, which there's only 8 reported cases in the world. So like that kind of makes it, kind of in the no lands, world. But a few things. So usually we don't do immunotherapy because usually it's relatively cold. However, because all of a sudden TMB went high from like 0.8 to 7.7, and other reasons, we inserted Nivo and Ipi, and that actually cleared my brain mets and got me to a complete response. So knock on wood on that phenomenal,
Congratulations.
response. And when the other stuff wasn't working, to be honest, like the chemo kind of working in the progression site, but not in the brain. It didn't pierce the CNS. And then once we scanned the second time, it happened. But so just to give you that context, but more importantly, you were talking about the immunosuppressive, cells like myeloid side, and aren't they, or myelosuppressive type of things? And I've read that there are like, can't you deplete them with like capecitabine or some other kind of complementary things that you can do? And the second question is on, you were just talking about radiation, which is something that I'm considering right now. The standard on the limited stage of small cell is concurrent chemoradiation, but in my case, it was extensive and once again very rare. So I spent some time with some of your colleagues, like Jim Walsh, like understanding, like, hey, should you, will the radiation actually kill some of your soldiers, or should it enhance it? And so, any thoughts on that would be appreciated.
Yeah, so great questions. And actually, I was going to say, I hope you met Jim, but yeah, so great. So in regards to myeloid cells, it goes back to one of my first slides where I was talking about the immune tumor microenvironment. Not all myeloid cells are bad. Some are actually good in that you want them, and some of them are bad where you want to get rid of them. And that's the trick. That's what we're struggling in the field, because right now we have ways of depleting many of them, but then we're depleting some of the good ones as well. What we're trying to work on are drugs that can actually transform the bad ones into good ones and sort of manipulate the ratio so you have more of the good and bad. And that's an active field of investigation, and not just in prostate, across all cancers, because we believe that's actually contributing to a lot of the resistance to immunotherapies across all cancers. So I hope that answers the myeloid question. The radiation therapy, Jim Welsh is one of the leaders in the field with radiation therapy and combining with immunotherapies. And I've seen his data, and we're collaborating with him from a prostate cancer side. And I believe he's correct that normally when we give radiation for cancer, we're trying to kill everything that we focus that radiation beam on, right? So some of you may have gotten or may have had localized prostate cancer, and you might have received radiation for the localized prostate cancer. What the radiation doctors are trying to do is they're trying to kill the entire cancer microenvironment. So that's also going to kill some of the good immune cells. What Jim is thinking about is maybe not giving such a high dose of radiation, but giving a lower dose where you may not effectively kill all the cancer cells, but you're going to boost the immune system so that it can work more effectively with the immunotherapy, similar to what we were talking about with Bob. And I think someone put in the chat with Dr. Stathu, who used to be here at MD Anderson and now is at Methodist. She sometimes combines radiation therapy with immunotherapy. Now, the problem is it all depends who you talk to with radiation therapy, because if you talk to people like Jim, he's going to say, don't give high doses. The traditional radiation oncologist will give high doses. So you have to be careful. And we're still trying to figure out what's the ideal dose, and whether you do proton or SPRT or EBRT. There's many forms of radiation therapy, and we still don't know what's the ideal one for promoting the immune system. Hope that answers both your questions.
It does. One just quick follow-up, and then I'll let everybody go. So if you're already on, let's say PD-L1 and CTLA-4, because all the trials always say, including like vaccines or ETCs or, bispecifics, they all, say you need to help, your immune system by adding one of these, inhibitor PD-L1 or CTLA-4, items, FDA approved. If you're already on it, and let's say that a year from here it's still working and it's great, is the effectiveness shift if now you added bispecific versus if I start the bispecific, the PD-L1 or the CTLA right next to the bispecific?
Yeah. So Ricardo, what you're asking about is if you're a responder,
Yeah.
and then all of a sudden your body stops responding or the cancer comes back, what's the next effective therapy, or can you go back to the CTLA-4? Is that
No, I'm actually asking, like, for example, let's say you're responding and it's still working, and if you had to compare one, that let's say that you add the CTLA-4 and the PD-L1 and the vaccine at the same time, so it's to get kind of together. But let's say that let's say ETC, or let's say the bispecific that you want isn't available right now, but you have to go on the PD-L1 or CTLA-4s, and then all of a sudden the bispecific or the DLL3 CAR shows up in a year from now. Is it going to be less effective because you already started the PD-L1 and CTLA-4 a year before, versus like in the ideal trial, it's kind of 40 days before you start these things. So I don't know if there's.
But I want to, so I want to just clarify, because in anyone that's responding, I wouldn't add anything else to, right?
Oh,
all right, but I think what you're trying to say is, even with someone responding, would you add these newer, more novel treatments like CAR T cells and bispecific? Is that what you're asking?
Yeah.
I wouldn't add it, because we have, what you don't want to do, or the way I think about it is, we have no evidence that in someone that's responding, that adding more is going to actually help you. Like, for example, if you add a vaccine to it, you may actually distract the immune system from actually doing what it's doing, because it's going to focus on what the vaccine is asking. And so I'd just be careful. If you're responding, I'd just let it be.
Interesting, because what you're effectively saying, because I thought that you at MRD, so like you're responding and you're not, the vaccine has very limited toxicity. I was of the view you unleash a vaccine right there, and then because microscopically there could be some stuff that you just can't see.
There could be, but at the same time, the vaccine is only focused on a few cancer antigens or proteins that are expressed on it. And it may be the ones different from what is actually progressing in your body. So it could distract, right?
Yeah. No, this is super helpful. Thank you so much.
You're welcome.
Sumit, could you turn off your slide screen share, and then we'll see more of these wonderful faces.
Yes.
Great. Next up is Russ Hollier.
Thanks. Dr. Sartor and Denmead think that high antigens from bipolar antigen therapy, for example, induce the prostate cancer to release immunogenic factors. What do you think about that?
I think that it's controversial. So we don't know yet. And Sam and I talk about this all the time, because the reason why it's controversial is that right now we know that hormonal therapies can boost the immune system transiently, but we also have a lot of data, both in patients and in preclinical models, that long-term hormones can actually cause a more immunosuppressive microenvironment. Sam is doing the clinical trials and doing the experiments now, both in mouse as well as I would say in our patients in clinical trials, to try to confirm his findings. But I have a feeling that when it comes to the hormone, or whether it's taking out the AR pathway or giving it back with a bipolar therapy, these things are going to be transient and they're not going to be long-term.
Do you think then that does that lead you to think that first of all, first question, hormonal therapies, do you mean high androgen therapies or low hormone? Typically prostate cancer, when they say hormonal therapy, is exactly the opposite, is hormonal ablation.
A hormonal
Do
ablation.
you mean
That's
hormonal
right.
ablation or
Yes, as a
sorry.
field, when we talk about hormone therapies, we're not thinking about what Sam's doing. We're talking about hormonal ablation.
Okay, so hormonal ablation then to follow up, you said hormonal therapies boost the immune system short term, but decrease it long term, or might decrease it long term. That's hormonal ablation
That's right.
that does that? Okay.
Yeah.
So what about the opposite, the high androgens?
Well,
do you think they
that's the
boost it
problem
short
is
term?
they're looking, Sam is the only one that's really actively looking at that in the world right now, and Johns Hopkins. And so they haven't shown me data enough to convince me yet.
Okay. All right.
I'm data driven. I mean, there's a lot of like hand waving, like this can happen, that can, great. A lot of things can happen. I can spit and I can make the immune system do stuff, but I want to see the data.
Yeah, me too. Do you have any idea when he's going to produce data for this in mice or humans, clinical trials?
Yeah, he's actually, I mean, we spoke recently and he's definitely actively doing it. I hope in the next 6 months to a year, they'll present it publicly.
Nice. Okay, thank you. Thanks.
Thanks, Russ. Next up is Jonathan Starr.
Yes, Dr. Subudhi, thank you so much for talking to us. This is a great thing. Sumit, okay. I want to go back on, you're talking about the cutting edge. I want to talk about the rusty back edge for a second, which is the Provenge or Sipuleucel T. Every doctor I talk to has a different opinion about that. So I would like to hear more. I mean, is this an effective treatment or not? And are there certain conditions under which it is effective, and other where it's not? Are there any? Is there any information on? Is there a tail of survival? I did look at this PROCEED retrospective study, which actually, which seemed to show a lot of survival benefit at low baseline PSA. On the other hand, maybe it's just it's just that because they were low PSA, they were earlier in the progression or something like that. Yeah. But anyway, I'm really curious to get, something substantive from you about Sipuleucel T. Is it something or is it not?
Yeah. So Jonathan, I got to be, I don't know if everyone saw my disclosures, but I am a paid consultant with Dendreon, which is the company that makes Provenge. But I'm going to tell you what I truly believe. Okay. So I don't want you. I have to share my disclosure so that it's clear. But my true opinion is that yes, it is effective, and I have a subset of patients that I'm trying to get Dendreon to publish this because I know Oliver Sartor, as well as many other people, have about 5% of patients that have long-term responses with, when I say long-term, they've gone 2 to 5 years without needing anything else except for the Lupron injections or, the ADT alone. And so it is effective in a subset. So let me just take a step back so that I get everyone on the same page. So why Jonathan's calling it old drug? As I mentioned, it was FDA approved in my slide deck in 2010. And so over a decade ago, it was the first treatment vaccine for patients with active cancers. There's a lot of vaccines out there for if you never had cancer, like for head and neck cancers and things like that are virally driven. And so those are preventative, like the Gardasil vaccine that they're giving teenagers to prevent certain types of cancers. But this was the first vaccine that was FDA approved for people with active cancer and metastatic cancer. I want to tell you the FDA label on it is for patients that are asymptomatic or minimally symptomatic. So if you're on narcotics for cancer-related pain, that you won't be approved for it. It also excludes patients who have visceral metastases. These are metastases outside of the lymph node and bone, meaning to the lung or the liver or adrenal glands. So those patients are also excluded. So it's a narrow patient, but a majority of our patients sort of fit that criteria. Where do I find it most effective? I tend to give it as a first-line treatment to castration-resistant prostate cancer. So as soon as I find hormonal ablation, so I'll be a little more specific because I believe that point was made really well with the last set of questions. So I'm talking about hormonal ablation. As soon as I see a rise in PSA, that's when I start talking to the patients about Provenge and trying to give it, because the data shows that the lower your PSA, you're more likely to have a benefit from Provenge. I do want to clarify that the PROCEED as well as the registration trial all showed that with Provenge, you do not change PSA, you do not change scans, meaning if your PSA is going up, your PSA will continue to go up. If your scans are showing worsening cancer, after you finish Provenge, your scans will even show even worse cancer. So then people always ask me, well, then how can you get a survival benefit if your PSA is continuing to get worse and if your scans are getting worse after you get Provenge? And my answer is that instead of the cancer going 100 miles per hour, after you get Provenge, it likely goes 60 miles per hour. So that it's slowing down. That's the only way you can get a survival benefit without these other metrics changing. But like I said, I have 5% of patients where the PSA will either go down or just stabilize, and I don't need to do anything, including a patient that I treated, I think at the age of 44, and he's now 51, and I haven't had to do anything since then.
Are you seeing any good combinations with
That's funny. I have a meeting with Dendreon and thank you. I have a meeting with Dendreon and another company that I can't say for combining potentially bispecifics with the vaccine.
Yeah. How about I'm going to throw something in, and let me say I have no connection with this company or any company. But you know, I've been following for a while this Veru 111 sabizabulin, and it's like an oral taxane kind of. It acts a lot like a taxane. It's an antitubulin, but in a somewhat different way from taxane. And it looked very promising to me. And they were going to come out, and then FDA said, "Oh no, you got to start all over again." But because it is not so immunosuppressive, because its side effects are so minimal, apparently, I thought, man, this might be a great thing to combine with Sipuleucel T. And I'm just wondering if that thought has ever occurred to you or anyone else.
Yeah, great question. So, by the way, Brad, you're right. The group is savvier than our average patients that we see, and like understanding the mechanisms of taxanes and things like that. So anyway, impressive questions. But so yes, so a lot of immunotherapies, not a lot, but in certain cancers like breast and lung, combining chemotherapy with immunotherapies have been shown effective. Now, to your question, Jonathan, whether or not having a taxane, oral taxane that doesn't cause the myelosuppression that we see, would that be beneficial? It may not be, because the reason why the taxanes may be working or traditional chemotherapies may be working is not just that it's killing the cancer and releasing cancer antigens, but it also may be taking away some of the bad myeloid cells, right? So we have to look into that. I mean, meaning we have to do the experiment, we have to test it out to confirm whether that's the case.
Okay, well, let me just say, I hope that sabizabulin survives, first of all, as an option, and perhaps you'll think about using it that way. Seems like an interesting clinical trial to do.
It does, actually. Agreed.
Okay, well, thank you very much. Very helpful.
Thank you, Jonathan. Next up is Brian McCluskey.
Hi, Sumit. So two-part question, just focusing on your last slide regarding bites. So the target was PSMA. And so the first question is, are there other promising targets for bites? And my second question, which is related, is there an optimal time to pursue bites? And so just some data on that is, I know that my RNA expression his actual my RNA expression for my PSMA expression for my PSMA RNA expression. Jeez, sorry, I'm just waking up. I think my PSMA expression has declined relative to 1,000 prostate cancer patients. Tempest data pretty dramatically. It's actually been cut in half since 2016. I have 3 data points. I was in like the 98th percentile. Now I'm in the 38th percentile. My SUV values are actually, low to moderate as well. And so that doesn't really seem like a great target for me to go after. And so I'm just curious, if I were to pursue a bite, would there be other targets to go after? And what is the right timing?
Yeah, great. So let me try to first answer your first question. Other targets besides PSMA, the ones that are being looked at in prostate cancer and have gotten the most attention are STEAP, TROP2, and B7H3. Those are 3 that are they're getting the most action. There are definitely others, but those are the ones that are definitely getting the most attention. So that's the first question. And then you got to remember, with these immunotherapies, you may not need to have high expression. You just may need a little bit of expression, different from the radioligand therapies, where we know, and Oliver probably shared some data coming from the Australia group and others, that you do need a threshold of PSMA expression on those PET scans to more likely respond from the lutetium or radioligand therapies. But I think it's going to be different from immunotherapies, but it's too early to say. But we've had some patients with lower expression PSMA that I wouldn't have thought would have responded to the bispecifics that are. So I wouldn't say that you're less likely to respond. Okay, at this point. All right. Then in regards to the optimal timing, in general, the field believes that the earlier in your prostate cancer journey that you're in, and when I say journey from initiating hormone ablation, okay, we believe that's probably the best time to give immunotherapies, because then you have less of the bad immune cells, like the immunosuppressive myeloid cells, because we know long-term hormonal ablation will bring those bad cells along. All right, that's data coming from the Bono's group from the UK, as well as Chuck Drake's group when he was at Columbia, and many others. And so we think that earlier is better. But as many of you know, most of the clinical trials start at the metastatic castration-resistant setting, and as there's some success, then you start bringing it earlier and earlier. And I'm sure Oliver showed you that with the radioligand therapy of lutetium.
Okay, just one follow-up as well. So expression may not be, the key factor that we're looking at here. But what about targeting B7H3 and TROP2? Is that being looked at? Like, why go after one target, right? Couldn't you be that much more effective if you went after 2, 3, whatever?
I think that the answer is yes, but the problem with all these different targets, they're not important for the cancer cell. The cancer cells will live just as fine right? Because they're not driver targets. Driver similar to what we talked about. Sorry, I'm terrible with names. I'm trying to look with Ricardo, who has an ALK mutation for his lung cancer. That's a driver mutation, right? You stop that, then the cancer dies until it transforms into something else, right? B7H3, PSMA, STEAP, they're not driver mutations. That's why I have issues with CAR T cells, because CAR T cells, if you look at the liquid data, you know, where it's FDA approved, the biggest resistant mechanism is that the cancer just stops expressing whatever the CAR is meant for. And that's the same thing that's hold true with radioligand therapy too. Like you'll see that when you see the patients that are not responding anymore, it's the lesions that don't express PSMA that's the problem. So there is and the same thing is going to be true with CD3 T cell bispecifics, but there's data to suggest that the CD28 bispecifics, they can cause antigen spread. What do I mean by antigen spread? So if the bispecific is targeting, let's just say B7H3, and the cancer downregulates it, the CD28 bispecifics trigger a broader immune response that will target other antigens such as PAP or prostatic acid phosphatase, which is what Provenge is targeting. It can target potentially STEAP and PSA and other things. So what we want in a good immunotherapy is to cause antigen spread, because that's how you can get the memory.
Got it. Cool. Thank you. I know there's a lot of questions. Thanks so much.
Okay, next up is Gita Peterson. Gita is with Genomic Expression. She does RNA-seq interpretation.
Yeah, and I'm not a prostate cancer patient, but I wanna really express my appreciation for the clarity at which you express your the science here. And I've spoken with some of these patients, and they're so well educated, but the way you also express it is super clear. The other thing that I want to dig into is your statement is, if the treatment is working, you don't want to add to it. And I don't know if you've seen the combinatorial treatments of mRNA vaccines, individualized mRNA vaccines with checkpoint inhibitors, and the results from skin cancer and pancreatic cancer. But I believe BioNTech has a trial in prostate cancer. So this is my ask or question. In my view, if you take the brakes up off the immune system, but you don't tell it what to do, you can be in a situation where it does havoc. You know, some of the side effects is autoimmune diseases. If you combine it and you boost the effectiveness and the responder rates, you could potentially also decrease the side effects. What's your thoughts there on the vaccine using mRNA technology in prostate cancer?
Okay, so I want to address a couple things. So I want to clarify, you know, adding on to treatments when someone's responding. There are people that I think are optimally responding, meaning let's stick with prostate cancer, because I know Ricardo, we're talking about lung cancer, but if someone's PSA is continuing to go down and the scans show that the cancer is shrinking, I'm not going to add something to that person. However, we have a patient that's on one of our bispecific trials where the PSA is going up, the cancer is showing stable disease, and we actually just reached out to Jim Welsh, our radiation oncologist, to see if we can actually boost his immune system. So the patient's responding in the sense that he has stable disease. He's not outright progressing. To me, this particular patient is having a suboptimal response, and I'm open to adding things. So I just want to be clear
Okay.
about
Okay.
responses with that. Okay, so that's just one thing. And yes, I've talked to that company as well, and they're early in their prostate cancer journey. So
Yes.
so they haven't quite got there. I actually think mRNA vaccines are exciting. I think that they give you ability to, I think it got brought up in the last question about having only 1 or 2 targets. You got an ability to have multiple targets, including potentially neoantigens, because with the technology getting better, you can personalize the vaccine, meaning the patient can give you their tumor, and then you can see what specific antigens are highly expressed. And many of you guys are using Tempus and other sort of technologies to get there. Our group is actually working with Boston Gene as another. And the reason why we've chosen Boston Gene, because we believe their immunoprofiling is one of the best ones compared to other companies. But you know, not trying to say one company is better, but that's just our experience so far. And so now it goes to combinations. I think that one of the major issues in prostate cancer that we haven't overcome yet, and why immunotherapies have largely failed, is because we treat it as a one-size-fits-all. So what do I mean by that? After you become, like, so when most people are diagnosed, they get a Gleason score, or you know, and they're saying, oh, you have a high risk, low risk, and if you have localized cancer, they'll tell you to either do active surveillance or surgery or radiation or both, right? But once you become metastatic, it becomes like, oh, have you ever received hormonal ablation? Have you not? It becomes a one-size-fits-all. How many lines of hormonal ablation have you had? Are you pre-chemotherapy or post-chemotherapy? If we thought about that, like if lung cancer, and Ricardo can attest to this, ALK mutations, I think, only represent, and I haven't thought about lung cancer in about 15 years, but back when I was a fellow. But if I remember correctly, it only represents probably 2 to 3% of all lung cancers. If crizotinib, which was the first ALK inhibitor drug, was tested in all lung cancer patients, it would have failed. But what the lung cancer group did was they recognized that there's a subset of patients that are vulnerable to this type of treatment. And Ricardo's one of those people that benefited. And what prostate cancer hasn't done is, like, okay, let's go back to lung cancer. They have histological. So they take the cancer, they look under a microscope, and they're like, oh, this is non-small cell lung cancer, this is small cell. And then with non-small cell, they break it down into adenocarcinoma and squamous cell. This is just looking in the microscope, not doing any fancy stainings. Then they, and Haymaker at MD Anderson is one of the leaders in this, then they genomically characterize the different cancers and say, okay, you are more likely to respond to this type of therapy, and to design clinical trials. I guarantee you, if immunotherapies were tested in all lung cancer patients, and we know that it's true, those trials would all be negative. But when you select out the lung cancer and don't treat them as a one-size-fits-all, then you start seeing the benefits. Where am I going with this? That's where we have to go with prostate cancer. We need to do the same things and identify the subsets, because there are some people that actually truly benefit from PD-1 monotherapy. There are some people that need a combination of ipilimumab plus PD-1. And then there's people that need triple therapy with myeloid. The issue with adding on more is you're also adding on toxicities. So we always have to balance this. And for some reason, and we're hypothesizing, we don't know for sure, but prostate cancer patients tend to have more toxicities from immunotherapies than any other therapy. So if you look at immune checkpoint therapies, if you look at CAR T cells, when you test them in prostate cancer, and I'm talking about the same exact therapies. So if you take a CAR T cell and you put it in pancreatic cancer, like a PSCA CAR T cell, because pancreatic cancer also expresses PSCA, and you put it in pancreatic cancer versus prostate, you'll see more toxicity in prostate cancer. We believe the hormonal ablation therapy may be contributing to that. So that's why I'm not a big fan of just throwing the kitchen sink. I also think we need to do adaptive design trials. What does adaptive design mean? So we start off with everyone getting PD-1, the responders, we just keep them on PD-1. The non-responders, let's start adding things. Let's start adding the anti-C4 or a vaccine. Let's start adding and start doing it that way. Then you'll start identifying who actually needs more and who doesn't.
Right. My second question is about the tumor microenvironment, and I think you alluded to it because it's something you could see in an RNA-seq data set, because all the immune cells has individual unique biomarkers.
Yep.
And so my question is, you're using Boston gene to analyze your own RNA-seq data? Is that what you're doing?
Yeah, so I'll give you an example about this. So Boston gene has a cancer cell paper from 2021, where they looked at mostly melanoma patients, but they looked at across many other tumors. And they show an immune landscape, and the immune landscape, they have immune-rich fibrotic and immune-rich non-fibrotic and immunological desert and some other.
Yeah.
And it turns out the immune-rich non-fibrotic are the ones that are more likely to respond across all tumor types.
Right.
Okay. And so this is where we can start using the landscape to help guide us. So what did we do with one of our patients? One of our patients actually was a MSI high. He had the mismatch repair defects as one of our other, sorry, I'm forgetting names, but one of the first persons to ask me a question today was, and who's getting Keytruda. But this person's MSI high showed immune-enriched fibrotic. So we're like, you know what, we're not going to give you Keytruda because you're more likely not to respond. We're gonna try to get you on a combination trial. So we are using it to talk to our patients to say, like, look, you're more likely to be in the, you know, the either the responder that only has a short duration, or you may not respond at all. And by giving you Keytruda, you may eliminate yourself from other trials, because a lot of these trials that are doing novel immunotherapies in prostate cancer exclude prior immunotherapies, with the exception of Provenge, because that's an FDA-approved immunotherapy.
Right.
Does that?
Excellent. I would love to speak more about that
Okay.
at a later stage.
Thank you, Geeta. Sumit, how much more time? We've hit the hour here. How much more time do you have?
I have about 10 more minutes.
Okay, we'll keep going as long as you have time. We have 4 more questions. There's all the 3 here, plus Amit has a question. So next up is Rick Davis.
You're muted, Rick, I think.
Rick, you're muted.
Hey, Dr. Subudhi. It must be 10 years ago. I sat across from Jed Wojcik, and I asked him about anti-CTLA-4 for prostate cancer, and he wasn't overly enthusiastic. And 10 years later, we really haven't seen IPI do too much. We've seen a lot more from the anti-PD-1s if the guys have the right markers, like Dr. Bob. My question is, pick your top 3 combinations with either anti-CTLA-4 or an anti-PD-1, PD-L1 to make the prostate tumor hot. Where do you think, how do you think we're going to make that hot with either immunotherapy? What's going to make it hot? What are the top 3 candidates?
Yeah, so sorry, a patient was texting me. So I want to clarify, because the field is starting to make a comeback with anti-CTLA-4, because there's this there's a lot of talk in the community as well as from patients that believe that PD-1 has taken over, and it has for the hot tumors, right? But at the same time, if you think of where bladder cancer, it only has a 15% response rate. The majority of bladder cancers don't respond to it. In melanoma, it's only 30%. That means a majority of people, 70%, don't respond to it. So I just want to be careful about, yes, PD-1 has more FDA approvals, but for most cold tumors or unresponsive tumors, you do need the anti-CTLA-4. Not all, but most of them. And so I think it's going to be making a comeback. And now that ipilimumab and tremelimumab are off patent, you're going to see the next generation of anti-CTLA-4s be developed, because they can actually make they have the ability to do a couple things: drive T cells into a cold tumor, and also cause antigen spread. So those are things they could do. So I just want to clarify those points. And then Tony Rebas from UCLA, who's a melanoma doctor, has shown that some of the patients who have responded to PD-1 have responded because of previous failures from anti-CTLA-4. So that anti-CTLA-4, his data suggests, and this is from patients, that anti-CTLA-4 modulates the tumor microenvironment so that in the future, the anti-PD-1 can be effective. So just want to put it out there that there's a comeback. So then what are my top three? So when it comes to prostate cancer, which is what I think about the most, I think that something that can get at the bone, and this is where I feel like the backbone most likely will be a bispecific in nature, at least at this time. Things can change. And then depending on what the resistant mechanism is, you probably have to add a checkpoint therapy. In addition, because prostate cancer has a lot of myeloid cells in it, you probably also need a myeloid inhibitor. Right now, we're looking at the adenosine pathway as targeting that as a way. Hope that answers your question.
Thank you, Rick. Rick Stanton, you're up next.
Hey, thank you so much. I'll just run down these questions. Let's see if we can just go fast, I suppose. I was very excited in Akoya technology to query the tumor microenvironment, but it seemed to have no clinical utility. Do you have interest in that, or is that moving forward?
So I'm not familiar with their technology. Can you sort of expand on that?
Yeah, it's imaging antibody, maybe. I guess it'd be like a standard IHC stain, except for antibody driven with multiple color floors. It's a stain and wash technology, so you can go up to like 50 or 60 deep. Inquiry CD8, CD4s, adenosine.
You're talking about, so there's different imaging technologies. So you're talking about in a patient, like where you're imaging the whole body, like a PET scan?
No,
or you're just talking about okay, got it. Okay. So
yeah,
sorry.
a biopsy.
Yeah. So great question. So what we've been talking about before with I was talking about Boston Gene and someone else was talking about Tempest. We were talking about doing bulk RNA-seq. And then more recently, single cell RNA-seq has gotten caught on vogue, but we believe, and this is what Rick is alluding to, that understanding the spatial relationship of where the various immune cells are within the tumor microenvironment is important. Just because the bulk RNA-seq or the single cell RNA-seq doesn't tell you where the T cells are. What if the T cells are in the margin of the tumor and not in the center of the tumor? You don't get that information from this approach. But these new technologies, Codex, the one that you were referring to, maybe these are new spatial technologies at the single cell level that will get you to tell you the spatial relationships. And they can do up to about right now, I'd say 40 to 50, most closer to 40 is accurate. They'll give you higher numbers, but in our hands, we can really we feel confident, really confident with 30. 40 is starting to push the edge, but the people who invented it, like Gary Nolan, will say he can do 50, 60, right? But one of the issues with it, and we're finding, is that the bioinformatics takes about 6 months. So companies like our bioinformatics team takes 6 months to do it, whereas companies like Boston Gene can turn it around because they're actually starting to use it, and they can turn it around in about 4 weeks because they have the infrastructure and the monies to do it. But I think that's the direction. I think when the bioinformatics catches up and the cost goes down, well, that's definitely where we need to go.
Okay, great. On a bispecific, I understand the 2 antibody arms, but what is the driving force to make that connection? In other words, how is that bispecific going to get to the tumor? Why wouldn't it just float around in the body and go away? I mean, what was actually just the affinity? That's it.
Yeah. So that's the key, that we don't know what that threshold is, and so one of the things that we're doing with the companies that we're working with, the PSMA bispecifics, is we're looking at the pre-treatment scans as well as the pre-treatment tissue by immunohistochemistry, because we want to look at the protein level as well as the transcriptional level to see what that threshold is to get a response. And because I have a feeling that there is probably some threshold where it's just too low, and we have to answer the question because it's so much easier to do it at the at the RNA level than protein level. And so, but sometimes RNA does not equal protein, meaning you can have high transcriptional level or RNA level something, but it may actually give you low protein, and sometimes they're correlated. So these are the questions we got to ask, and we are asking.
How do you feel about B7H3?
We're
Probably-
excited about it. We're working with Macrogenics to try to bring that into our clinic.
I'm probably going to go on that clinical trial out of UCLA very shortly.
I've had some patients respond to it. And I'm not running the trial. Our phase 1 group is, and I've sent my patients there, and some are doing well.
Okay, I hope I'm one. TLR agonist to boost immune response in the TME. That was something that I was excited about 5 years ago. Is anything happening there?
Yeah, I think the problem with a lot of TLR agonists, you have to inject them, right? And prostate cancer is not an easy cancer to be injecting unless we can figure out how to inject it into the bone. But even that's going to be, not easy to do. It's not something that you can just do in clinic readily. Melanoma is a lot easier, of a cancer to do that with.
Okay. I worked at Amgen 17 years. I live in the shadow of Amgen. My Amgen homies I see on the park, they say, hey, we got this new bispecific. You really need to check it out. Are you excited about Amgen's bispecific?
Yeah, we're running trials with them, but I can't share more than that because they're so early, and anything I can say can change stock markets.
Sure. I'll skip just to note I was pals with Arcus folks. I used to report to them while I was at Amgen, and I went on their PD-L1 adenosine inhibitor. Didn't work. Could I have gained predictive insights from RNA-seq or other assays that would say, yeah, you're probably not going to respond? Would you RNA-seq?
I'm the national leader on that trial, and
oh, really?
Yeah, and I have some patients that did respond really well and continue to. So, yeah. Wow,
you know Terry Rosen?
I don't know Terry actually.
Oh, he's the CEO of Arcus.
I haven't met Terry
yet. In my youth, I developed a cancer battle map to try to, which contained the cells that you showed earlier, the good cells, the bad cells, and decorated the expression from RNA-seq onto the battle map. I kind of left that behind just because I, ran out of juice. Do you see value in that? Would that actually have a clinical utility?
It's hard right now because it's all you have to contextualize it. That's why even when I try to create an algorithm and try to share it with other institutions and colleagues, it's difficult to do because you need more context. And so with that, Brad, I apologize, but I have a hard stop. But I know there's more questions. You can please share my email with the group, but just please make sure the subject line maybe include Brad's name on it, Brad Power, and then that